Okay, we will talk about maintaining the partogram. The partogram is not new, but this was done few years back when we started introducing the partogram. So, the partogram, as I said last week, is a graphic representation of the events in labor, and all observations are made on the mother, and the baby or the fetus are plotted on a single sheet, and it helps us to recognize early any abnormalities in the progress or any abnormalities with the mother's well-being or the fetal well-being or the fetal distress. So, this is the national partogram which you will see. The first component, the first upper part strip has the bio data or the demographic data of the mother, gravidity, BHC number, blood group, parity, date, time, and any special problems like that. Okay. And then the second portion has the times of the vaginal examination. You can see that the hours are from the admission and not more than 24 hours. And then the next portion tells us about the stage of the labor, and during this period, depending on the stage, whether it is first stage or second stage, you mark the fetal heart rate. Now, in the first stage of the labor, usually we mark the fetal heart rate every half an hour, every 30 minutes. In the second stage, in the active phase or the latent phase every half an hour, in the active phase it is every 15 minutes. When it comes to second stage, it is after each contraction or minimum every 5 minutes, but better to auscultate after contraction. And then this column says about the CTG information, and this is the time duration of the contraction. The duration of the contraction, it can be marked in minutes. This is marked in the interval between the contractions, contraction free interval. Now, you can see in the early stages, the interval between contraction is around 5 minutes, and it comes to 4, and then gradually it becomes less than 1. So, that is how. So, this is a ascending type of a graph. In that, duration of the contraction is indicated by these dots, right. So, when it is crosshatched, it is less than 60 seconds, so 40 to 60 seconds. Exact marking is there on the other side. We will come to that later. And then this part is the rate and the drop rate of the infusion of syntocinon, if you have started on syntocinon. And after that comes the descent and the cervical dilatation. This descent is marked from this area, abdominal descent. From high up, it should be going negatively, in negative direction, and cervical dilatation should go in positive direction, upwardly. Cervical dilatation is marked this way, descent from here downwards, and this bit shows you the digital examination, vaginal examination findings, positions, lico color, caput, molding, whether it is there, and the descent is marked with this. And please note that we mark the dilatation and descent in the middle of the square. So, it is in the middle of the square with a dot in the dilatation, with a cross in the descent. Here again vaginal examination findings, again gestation is with a cross. And then we have mother's observation, pulse rate, blood pressure and the temperature, and any actions if you have taken, say positioning, giving oxygen, fetal blood sampling or whatever, are generally written here in a small abbreviated form. And then this bit is actually for the first stage. In the second stage, heart rate, you usually before writing you need to note down the time of full dilatation, and then traditionally we will allow about 1 hour, but the newer teaching is not to allow 1 hour for the head to descend, to start pushing immediately the moment you noted. But this was devised little earlier, so it has 2 times. One is the notation of the full dilatation, and then the time which commences, usually about 1 hour afterwards. If the patient is on epidural, it could be even 2 or 3 hours later, depending on the fetal well-being. And then the heart rate in the second stage is here. And this part marks the heart rate of the fetus in the second stage. Every 5 minutes or immediately after contraction. In the passive phase, if you allow 1 hour, you can mark the heart rate every 10 minutes, but it is not applicable now. 5 minutes is the minimum usually, and better if you can do it immediately after each contraction. So, when should we start the partogram? The normal timing is when the frequency of uterine contractions are 2 per 10 minutes or more. Or if you are starting syntocinon or augmentation, you need to start it. If the patient is on spontaneous labor, usually we start the partogram at 4 centimeters dilatation. Fetal heart rate recording, these are the minimum standards. 4 centimeters from 4 centimeter dilatation every 30 minutes, and 4 to 10 up to 4 centimeters every 30 minutes. That is the passive stage of the first stage. Active stage phase starts from 4 centimeters. Again, these are not current. Now we take it as active phase as 6 centimeters to 10 centimeters, but still better to mark every 15 minutes, because this is the government regulation and this is what the partogram has been, the instruction which had been released in the partogram. So, every 15 minutes 4 centimeters to 10 centimeters. And in the passive phase, as I mentioned earlier, it used to be every 10 minutes, but no longer. It is better to get it after each contraction or at least every 5 minutes in the second stage. And you can mark the commencement of active phase even here with the line, and generally if the CTG is suspicious or abnormal, we put it normal, pathological or suspicious, NSOP in the CTG. The contractions which we saw earlier are documented like this. You need to do it every half an hour. This is the duration of the contraction. So, it starts, and if you keep your hand on the fundus, you will feel the hardening, and then it gradually relaxes. And then from the first contraction to the next contraction is the interval between the 2 contractions. So, in the partogram you measure those 2 parameters. The strength of the contraction, If it is less than 20 seconds, it is dots. It's between 20 to 40 seconds, it is slanted lines, cross hatched between 40 to 60 seconds, right. Same here, less than 20 seconds, 20 to 40 seconds and 40 to 60 seconds. And traditionally we have two lines drawn on the partogram. Now, if you can remember, I told you last week that this alert line is started at 4 centimeters, 1 centimeter per hour. That is the traditional thinking which is still there, but now the evidence is that 1 centimeter per hour dilatation is not realistic in every mother. Each mother behaves in different ways in the pregnancy. So, some of them will dilate 1 centimeter per hour, some are less than that, some are more than that. So, it depends on the parity and each mother's behavior. So, the multipara generally will dilate more, whereas a primi might dilate little slower. So, each person differs, and we do not take many decisions nowadays based only on the alert line and the action line, but to facilitate decisions about transfer or whether decisions about too much of a prolonged labor, we still use these two lines. So, they still have their uses. So, you need to draw 1 centimeter per hour on alert line and then action lines, especially useful when you are managing deliveries in the periphery in as outpatient medical officers. If you are handling a labor, if especially you are allowed to handle multiparous women in their second or third para, in those patients you can decide whether if the action line is getting crossed or it is going to be crossed, better to transfer than and assume that it is going to be a prolonged labor. So, draw the action line 4 centimeters to the right. So, this is the cervical dilatation from 4 centimeters and 4 hours and then your action line. And you can see the abdominal descent marked here. All are in the middle of the square. Okay. And descent is done by palpation by keeping your hand above the symphysis pubis. If it is not engaged, it is 5/5. If it is 2 fingers, it is 2/5. Right. So, this is the pelvic brim. This is how the engagement happens, and you can note that down, and then descent can be marked on the partogram. Lyco color, and the lyco is maintained in intact membranes, clear lyco, meconium stained, blood stained or absent lyco. So, some absent lyco is generally either sign of a complete leakage of lyco or obstruction from the head. So, in those cases we push the head a little bit and see whether we can obtain lyco. Even with that, if you cannot, then you put it as absent lyco. Then the molding, a good sign of obstruction, which can be documented if as 0 if the bones are separated and you can feel the suture lines clearly, and if bones are touching each other, it is plus, overlapping but separatable on the pressure, it is 2, and +3 if it is overlapping and you cannot separate them with your pressure on the bones. So, that is how you note down the partogram in the first stage. And then the second stage, you note down the time of full dilatation, commencement of pushing, and then you mark the pushing with this arrow. Okay. And during the intrapartum period, you measure the mother's pulse rate every 30 minutes, blood pressure every 4 hours. But if the mother is having a heart disease or any other issue which you might need to document, say somebody who has had a sudden drop of blood pressure during labor, it is better to monitor that mother separately with the bedside monitor or multi-parameter monitor. If most of the labor rooms have at least one multi-parameter monitor, use that rather than going with this. But all the observations you document in the partogram, apart from documenting it in a different sheet. And then after the delivery, this part is now taken off from the partogram. At the initial stage, in the back side of the partogram, we had this information, but now we have separate modified early warning, obstetric early warning score called MEOS chart printed in color, which you can learn separately, and that is done to maintain the after the delivery part of the mother's care, postpartum period. So, I am not going into detail. Actually, you can watch my YouTube video on that, which gives more information, as well as on S-bar technique of handing over and taking over of patients. So, follow that video for more information. Okay. So, these are now redundant. Right. So, if any observations are abnormal during labor or after the delivery, you need to discuss with your seniors, SHO, registrar, senior registrar or their consultant, and then take decision. But at the same time, speak to your nurses and midwives who are there in the labor room. Since they have been there for several years, they might have some good advice for you. So, don't be too arrogant, always be humble and learn from everybody. So, that is the bit on the